Da tror jeg at vi begynner monologen fra denne siden av rommet. Det er flott, det er mye kommunikasjon, og fint det er mye å snakke om blant dere. Og det får jeg også bare fortsette med, men vi må også passe litt og akte oss med programmet. En veldig liten ting, Blodkreftforeningen har jo det vi kaller likepersoner, og det er i alle fall 2 av de som er her, som dere gjerne kan snakke med. Hvor er dere? Det vet jeg ikke riktig. Ja, her har vi en der, og en her. Det er i alle fall de som har vist henne. Bare spør hvis dere har lyst til å snakke med noen, og der snakke med noen, for å finne andre som kanskje er i noenlunde samme situasjon. Det som jeg kaller det, det er å møte litt kolleger som strir med det samme. Det kan iblant være litt nyttig. Jeg vil ikke si så mye mer om tjenesten, for nå skal jeg ønske Dr. Hermann Einsele velkommen til Oslo, til Norge. Og jeg er veldig glad for, I'm sorry I'm gonna do this initially in Norwegian, men veldig glad for at han kunne komme. Jeg hadde gleden av å høre på han i Danmark i fjor, og tenkte han må vi ha med på myelomatose-seminar i Norge neste år, og han svarte umiddelbart ja. Og en ting nå kommer han til å holde det foredraget på engelsk, veldig mye om immunterapi, og når dere har spørsmål, så kan dere gjerne stille de på norsk. Nita Moore vil være med å oversette spørsmålene, og hun vil også være med å gi litt informasjon omkring spørsmål der hvor det er uklart det som Einsele nå snakker om. Han kommer fra Universitetssykehuset i Würzburg, er professor og doktor, og holder på med forskning, og har etter hvert bygd opp noe som er absolutt et senter for immunbehandling, CAR-T-behandling av myelomatose i Tyskland. Kanskje det aller mest sentrale. So, I just explained that I first time listened to you in Denmark last year. I was very impressed, and we are very happy that you're here today. We just give you the floor. You make your presentation, and we will have a chance for translations of questions and eventually any details in your presentation that needs some more detailed description or translation. So thank you for coming. Thank you for joining us. I'm very happy that you're here. And for people in Trøndelag and Trondheim who looks at the TV or at the screen, he will be in Trondheim tomorrow. So thank you for coming. Thank you for joining us. We are proud to have you here.
Thank you very much indeed for this kind introduction, and sorry, my Norwegian is extremely poor, so you have to cope with English, unfortunately. Now, first of all, I want to thank you all for the kind invitation to your beautiful country. Last night I had the chance to see a bit of Oslo, and we had a fantastic meal, so I really enjoyed my first day in Oslo, and I hope that we have a very nice conference now, and I'm looking forward to your questions after my talk. So I was asked to kind of cover especially novel T-cell-based immunotherapies. Now, when I started to work in the field of myeloma was a disease which was not really fun to work. And between 1971 and 1996, the median overall survival of myeloma patients was only 30 months. And up to 2006, it slightly improved, so the median survival was only 45 months. And that we have normally a meeting in the new year when all the different hematological diseases are presented and the success is presented. I know I was always put after Hodgkin's disease. Now, Hodgkin's disease is typically a disease which can be extremely well controlled. And it was always sad when I came after Hodgkin's, which was so successful, and I had to show that in myeloma we didn't really improve. But that has dramatically changed. And this is mainly due to the fact that we have a lot of new drugs in myeloma. There's no other cancer in the world where there's so many new drugs approved like in myeloma. Now, when you have so many new drugs, you have to deal with these drugs. You have to know how to really use them, how to combine them, how to sequence them, and you need experts. And I know in Norway you have experts that can deal with this kind of treatment and can improve and use the novel agents that are now available for multiple myeloma. So just an example how much we have improved. So this is the current treatment scheme for patients up to the age of 70. In Germany, sometimes we use it up to the age of 75. Here we use 4 different drugs for induction. We do then give a transplant, then again these 4 drugs, and then maintenance. And the current data coming out of this trial, which is the most recent protocol for treatment of multiple myeloma, is that after 4 years, 84% of patients are still disease-free. And the prediction is that the median progression-free survival of these patients, so 50% of the patients are still disease-free after 200 months. That's 14 to 15 years. So looking at the old data, this is a dramatic improvement that we have seen in the treatment of multiple myeloma. And what we also know, the better the response quality, the better is the progression-free survival. And you probably heard about this minimal residual disease when we look with very sensitive technologies into the bone marrow and look for tumor cells with a high sensitivity. And if we don't find these myeloma cells anymore after the treatment, then the survival is even better. And the prediction is that after 4 years, about more than 90% of these patients are still disease-free. So you see, the strategy is to combine new agents and to try to get a very, very deep remission that even with very sensitive techniques, we are not able to detect any myeloma cells anymore. Now, this looks very nice, but we still have issues. And one of the issues are these patients with a high risk. High risk, probably you heard about this, is defined by different cytogenetic markers, so the genetics of the myeloma cell. We know, for example, that 70p deletion or mutations of a TP53 gene or other high-risk features, these are associated with a less favorable response. And what we also know is that patients that relapse early after first-line therapy, especially after the transplant, have a less favorable response. So these patients need new treatments. And with all the drugs that we are now using in first-line therapy, it's getting even more difficult to successfully treat in second and third line. And often patients already in third line have received most of the novel agents. So especially patients that have received most of the new agents, that means lenalidomide, bortezomib, daratumumab, if they have received all this and are still progressing, then the overall response rate of these patients in third, fourth line therapy is getting really bad. Overall response rate only 30% and the median progression-free survival about 4 months. Now, I don't know, do you want to, or should we continue? Is it okay, or should we stop and do some interpretation, or? No, okay. So, what can we do now for these high-risk patients and patients that are relapsing in spite of this effective first-line therapy? There are new drugs One is selinexor, another one is melflufen, then the belantamab mafodotin, which is a kind of a immune conjugate, so it's an antibody linked to a cytotoxic agent, and also the new cereblon modulating drugs, the so-called CELMoDs. These are the new pomalidomide, new lenalidomide, and they're much more potent. And you can see that even patients that have failed all other treatments now have quite nice responses. Unfortunately, the progression-free survival is not so long. So the real revolution in myeloma therapy now is the T-cell based therapies. And T-cell based therapies are treatments that are using the patient's own T-cells to attack the tumor. And I'm always asked by patients when I see them in my outpatient clinic, and they come and they have a relapse of their multiple myeloma, they say, why is my immune system failing to control the tumor? I'm able to control most of the infections, but unfortunately my own immune system is obviously unable to control the tumor. And the reason why the immune system is failing is because in the body of a patient who has a cancer, for example, a myeloma, very few immune cells are able to recognize the tumor cell and to kill the tumor cell. So the idea is, if a myeloma patient, for example, has a good immune function, and you have good immune function because most of the infections you can control, so the idea is to redirect your immune cells and to teach them now to attack the tumor cell. And this can be done by two strategies. One is the so-called T-cell engaging antibodies, bispecific antibodies, and the other one is CAR T-cells. And I'm going now to explain both in more detail. So first of all, CAR T-cells. So what you see here is a typical immune cell. Often these immune cells are specific for viruses like EBV, CMV, influenza virus, COVID. And they are very able to attack these viruses when they are going to infect a certain cell. But unfortunately, for example, a myeloma cell is not recognized by these cells. So the idea now is to insert a kind of a new receptor. It's like a telescope into the immune cell. And this is done like this by genetic engineering. Now you see this new receptor, this green thing here, the so-called CAR, chimeric antigen receptor. And this new receptor now allows the immune cell to recognize the tumor cell and to bind to the tumor cell. So suddenly a lot of surface molecules that are invisible for the immune cell are now able to be recognized, and you can see that now the immune cell carrying the CAR is binding to this immune cell. And now there is a so-called immunological synapse formed. And the next step is by this binding of the immune cells to the tumor cell is attacked and is being killed. So this is very nice, and we are able to do this. Now the question is, how can we transfer this technology into the clinic? The idea is that we take cells from a patient, that we select the T cells, these immune cells, that we cultivate them in the dish, that we insert this new receptor, this telescope, expand these cells, then we give the patient a so-called lymphodepletion therapy, a kind of a not very intensive chemotherapy, which mainly dampens the efficacy of the normal immune cells, so that we then, when we infuse the genetically modified, the CAR T cells, that they can fantastically expand in the body. And this is actually possible. You can see here we infuse these CAR T cells into a patient. So the patient had a very low lymphocyte count, very few cells in the peripheral blood. And then we infuse the CAR T cells, and you can see how nicely these CAR T cells expand. So in this patient, we then had more than 10,000 cells in the peripheral blood that were all carrying this receptor. And these were CD4 and CD8 cells. So nearly more than 90% of all the immune cells in the body of these patients were carrying this CAR T cell. And you can imagine that with these many cells that are now recognizing the tumor, the immune system is now very fit to attack the tumor. And then the question is, it's nice, they go in, they expand, can they persist in the body? And they can, and there have been patients now in the US that even 10 years after this one infusion of the CAR T cells still have the CAR T cells in the body. So they circulate, and they are kind of a police that is looking for tumor cells, and if they come out of their sanctuaries, they are being attacked and eliminated. Now this is all nice, but does it also work in the clinic? And the first patient that actually was treated with CAR T, or one of the first patients, was a young girl, Amy Whitehead. She was 4 years old, and she received intensive chemotherapy, failed these immunotherapies, then was advised, we cannot do anything for your daughter, she is going to die. So they decided to have a CAR T cell therapy for her daughter. And Emmy got the CAR T cells, and now in the middle, you see Emmy now 10 years after the CAR T cell therapy. So she had a tumor that was completely refractory to any chemotherapy, got one infusion of CAR T cells, and 10 years later, you see a nice young lady. She's completely free of tumor. She's cured with only one infusion of CAR T cells. So this was the example that this can work. Unfortunately, it does not work in all patients. But also the pharmaceutical industry, and we need the pharmaceutical industry as partners, they got really interested. If this is possible, that with one infusion you can cure a patient who is completely refractory to chemotherapy, this is a strategy which is worthwhile to follow. And therefore, we have now the approval for 6 CAR T cell products in Europe and the US for different indications. Now, I want to just tell you what is the right patient for immunotherapy, just to discuss whether certain kind of circumstances are making a patient a candidate for immunotherapy. So the first one is a patient with a newly diagnosed myeloma and renal failure. Currently, this is not a candidate for CAR T cell therapy. Why? CAR T cell therapy are only approved for second or further lines of therapy, and at the moment with renal failure, we have an issue that we cannot do a proper bridging of lymphodepletion therapy. So this is not a patient for CAR T cells. The next one is a patient in 7th line therapy with severe neutropenia, thrombocytopenia. This patient has received a lot of therapies, but because of this severe neutropenia and thrombocytopenia, these patients might also not be an ideal candidate, because following the CAR T cell therapy, we often see that the white blood cell count and the platelet count is decreasing. So this is not an ideal patient. Next one is a good patient. Early relapse after stem cell transplantation, especially when the patient has received lenalidomide, that is a classical indication now for CAR T cell therapy. Also, a patient who has received 3 lines of prior therapy, including a PI, IMiD, and a CD38 antibody, also a good patient. This is very rare, and I think in Norway you have very few patients who received an allogeneic stem cell transplantation. Allogeneic stem cell transplantation, especially if the patient is still receiving some immunosuppression, is probably not an ideal patient for CAR T-cell therapy. And then newly diagnosed myeloma and high and ultra-high risk disease, this is, I think, in the future, a classical indication for CAR T-cell therapy. So just to show you a patient that we treated in Würzburg. So this was a patient at the time when he came for CAR T-cell therapy was 72. He had received a lot of treatments, induction therapy, relapse therapy, 2 transplants, then pomalidomide-based treatment, carfilzomib-based treatment, another transplant, then again pomalidomide, and then what we normally do for bridging therapy, KDD-PACE, so a quite intensive combined treatment, and the patient completely failed everything. Now this patient was then put on CAR T-cell therapy. And he also had extramedullary lesions, so he had all the high-risk cytogenetics, very refractory disease, extramedullary lesions, and the patient received CAR T-cells, and you can see here this extramedullary lesion which completely disappeared. So after 1 month, the patient already was in a complete remission. And now your question would be, is this a typical situation, or how many patients are actually responding like this one? And how long will the patient remain in remission after this treatment? Now, these are data from the so-called KARMA trial. Here, Abecma, so a CAR T-cell product, was given, and you can see even in patients that had received 6 lines of prior therapy, including high-risk patients, extramedullary disease, 81% had a response, 35% achieved a complete remission, and the progression-free survival without any treatment was nearly 1 year, and patients that achieved a complete remission had a progression-free survival of about 2 years. Even better is the treatment with cilta-cel, the other CAR T-cell product. Here the overall response rate is nearly 100%, 97%. 82% achieved a complete remission, and the median progression-free survival, so the time without any treatment but being in remission, even in these heavily pretreated patients, was 3 years. The toxicity is, I mentioned already, some patients have cytopenias, so neutropenia, thrombocytopenia for some time, and then we have to substitute this or give growth factors. And in very rare cases, these patients also develop neurotoxicity. So in some of the patients, they saw some Parkinson's syndrome occurring. But this is happening mainly in patients that go into the CAR T-cell therapy with a high tumor load. Now, obviously, this is in very late line therapy. And now the idea is, if we have an immune therapy, we want to use it not very late in the course of the disease, but rather early, because then we have fitter T cells, and also the disease is less aggressive and less pretreated. So in this study, the so-called CARTITUDE-4 trial, patients were allowed to receive CAR T cells already in second line, so for the first relapse. And in this trial, first of all, the response rate was so good that we have never seen anything like this before in myeloma. Nearly 100% of patients had a response, and nearly 90% had a stringent complete remission. So you see the potency of these CAR T cells. Also, what I thought was very interesting in this trial is that it can take some time until a patient achieves the best response. So after 1 month, only very few patients have a response. But then, after 3 months, already 66% of patients have a response. But if you wait for 1 year, then 100% nearly of the patients are responding. So you can see that these CAR T cells are kind of expanding in the body of the patients that are continuously attacking the tumor cells and eliminating the tumor cell until after about 15 months, then nearly 90% of patients are achieving a complete remission. So it's really, that's why we call CAR T cells a kind of living drug. They remain in the body after one infusion and keep on killing the tumor cells. And what you see here is that it makes sense to use CAR T cells earlier. The black line are patients that receive 6 lines of prior therapy. The red one, 1 to 3 prior lines of therapy. Means that the earlier you give the CAR T cells, the more effective they are in treating and killing myeloma cells. And also, if you now look into this trial, you can see that if you give it after 1 line of therapy, 2 lines of therapy, less pretreatment means higher efficacy and better tolerability. A big question always is, do also high-risk patients benefit from CAR T-cell therapy? And here we specifically look at high-risk and standard-risk patients. And what you can see here is that the standard-risk patients clearly respond less to standard therapy, standard of care. But if you use CAR T-cells, the response rate is the same if you go for standard risk or high risk patients. So the CAR T cells seem to overcome these high risk features. And also here now looking at specific groups of high risk patients, you see in black is standard treatment, in red is CAR T cell therapy. You see the overall response rate, which is always much better for the CAR T cells, especially complete remissions, when compared to standard risk to standard therapy, independent of the patients have T414, translocation 70p, modification of 1q chromosome. So all the high-risk patients are definitely benefiting from this CAR T cell therapy. Now, you can also see that if a patient achieves a MRD negative situation, then the chances of long-term survival is extremely good. Now, a big question, patients always tell me, great, fantastic responses, but how do patients feel after CAR T cell therapy? Are they regaining the old quality of life? And I want to show you one patient that was very impressive for us. This was a patient who had a high-risk myeloma, who relapsed 3 months after tandem transplantation, so really high-risk situation. And then he received CAR T cell therapy, and he went into complete remission, into stringent complete remission, MRD negative. And so you can see here, the prognosis of this patient at that time was very bad. So in February 2020, he received his CAR T cells. In March 2023, 3 years later, he was still MRD negative. And when I asked him how he feels and whether he has regained his quality of life, he sent me this picture. And he finished a cycling tour from London to Paris. And you can see in front of the Tour Eiffel that he was really in good shape. And this year he sent me another picture, so he did it again.
What is his age?
He was 45 years old, yeah. Yeah, but I have patients that are 65 and they're really extremely fit, yeah. So it shows that if CAR T cell therapy is working, you can really regain the old quality of life. Now switching gears, now we come to the bispecific antibodies. And again, the idea is, how can we redirect the immune cells of the patient to attack the tumor cells. Now here we are not using a genetic modification of the cells, but we use a small molecule, a so-called bispecific antibody. And these bispecific antibodies have two binding domains. You see a red one and a green one. With the red one, they are binding to T cells, and with the green one, they are binding to a tumor cell. So this is now an immune cell which is specific for flu, cannot attack any tumor cell. Now we use this bispecific antibody which is binding to the CD3 molecule on this immune cell. And now with the green binding domain, it's binding to the tumor cell. So again, you have this kind of link between the immune cell and the tumor cell, and this kind of immunologic synapse now allows the immune cell, which is specific for flu, to kill the myeloma cell. But this is different from CAR T cells. So here you stimulate cells to become tumor reactive, but this persists only for a certain time period, and then the cells are losing their specificity. So you have to re-infuse. So this is not a one-time therapy, but it's a kind of continuous treatment with bispecific antibodies. And just to show you a patient that we treated, again, you can see high-risk myeloma, 2 transplants, received daratumumab combinations, carfilzomib combinations. So again, at 2020, this patient was run out of treatment options, and we used the bispecific antibody and treated the patient. And you can see how nicely these patients also responded to the bispecific antibody. And often these patients already after 1 month are in complete remission. So one of the big questions that we ask now about bispecific antibodies is how long do we have to give bispecifics, and what are the treatment intervals we should use to optimize treatment with bispecific antibodies. This was actually the first study with bispecific antibodies used in multiple myeloma, and we were very happy to be part of this trial, and we actually had the first patients that achieved complete remissions with bispecific antibodies. So we learned that they can be very effective, and that even after stopping bispecific antibodies, the responses can persist for quite some time. And this was also shown for bispecific antibodies that are now also available here in Norway and in Germany. For example, teclistamab. How many of you are receiving teclistamab? Anybody? 2. Okay. And how many are receiving elranatamab? 1 per. Okay. Thank you. And so you see here is the data for teclistamab. So after nice response rate. Response rates are lower than with CAR T cells. With CAR T cells, you saw about 99%. Now here it's 63% response, and the complete remission rate is 39%, and the median progression-free survival is about 1 year. And the same applies also for the elranatamab, which is a slightly longer, the median progression-free survival, but that's probably not due to the fact that the drug is more effective, but that they were kind of learning from the teclistamab experience. And now you see there is a lot of bispecific antibodies available now that are targeting BCMA. There are also bispecifics targeting GPRC5D. Is anybody receiving talquetamab here? No. Is talquetamab available in Norway? It's not. Okay. So these are the different response rates. So you see it's about 60 to 70% response rate. It's about 40-45% complete remission, and the median progression-free survival between 11 and 15 months. One of the big problems that we see with bispecific antibodies is shown here. that are infectious complications that can occur in about 40-50% of patients with severe infections, and they can be very peculiar infections like cytomegalovirus infection, adenovirus infection that we normally don't see in a myeloma patient. So again, what can we do? So this was a really elderly patient. She was 88 years old when we put her on a bispecific antibody. She was already in fifth-line therapy and tolerated the treatment not very well. Also didn't respond anymore. There shows you finally had 9 lines of therapy. And then we switched her to teclistamab, so a bispecific antibody. And she came into a complete remission, was even MRD negative. That's very nice, in an 88-year-old patient. So I don't think there is an age limit for bispecific antibodies. In CAR T cells, we have the upper age limit in our unit of about 80, 82 years. But with bispecifics, we would accept elderly patients. But the patient had several infectious complications. And I think here you need experts to really deal with these bispecific antibodies and the infectious complications. Again, I think Frederick, he knows how to deal with this. So what can we do? First of all, we shouldn't continue with bispecific antibodies every week. That's something I think we all learned. We should extend, especially in patients responding, we should extend the treatment-free interval. And we have now started to actually use bispecific antibodies only every 4 weeks to really allow the T cells to regain function. Because you can imagine that if you hammer these T cells every week with a bispecific antibody, at the end they are exhausted, and this exhaustion induces infectious complications. And it was actually a group in the Netherlands and also in the US that showed that by extending the treatment-free interval from 1 to 2 weeks, they could already reduce the rate of infections dramatically, and also that the efficacy was maintained. And I think that's the way to use bispecific antibodies. And I already explained this, that a lot of patients are developing these infectious complications, very rare infections like adenovirus, Epstein-Barr virus, BK virus. So we really have to be aware of these infections in patients with treatment with bispecific antibodies for multiple myeloma. And one thing which is very important, I guess, that we are doing this in Oslo in all the patients, that we give immunoglobulin infusions every 4 weeks, right?
At least if they have below 4 grams per liter.
Okay. Because this is definitely reducing the rate of infectious complications. Now, a question is that comes up, of course, in patients that have received CAR T cells and have a relapse after CAR T cells. Can you retreat with a CAR T cell after a CAR T cell therapy? Now, you shouldn't use the same one. This is not very effective, but you can switch to another construct. And here we switched from BCMA targeting CAR T cells to GPRC5D targeting T cells that can still induce very high overall response rates and complete remissions, even in a patient who has received CAR T cells before. What you can also do is to treat a patient who has received CAR T cells with bispecifics afterwards. And bispecifics still work in a patient who has received CAR T cell therapy. And it doesn't seem to have an effect on the efficacy of the bispecific antibody. So bispecific after CAR T cells can be done. So what about CAR T cells after bispecific antibodies? Now, this is not working. Here you see the green curve are patients that received the bispecific before and then were treated with CAR T cells. And clearly pre-treatment with bispecifics is dramatically reducing the efficacy of CAR T-cell therapy. It might actually change with some new tricks, but in principle, in a patient who is a candidate for CAR T-cell therapy, I would not treat this patient with a bispecific antibody. And that was shown also in other trials. So what can we do in a patient who has, for example, received a bispecific antibody, like this patient, had a beautiful response, then relapsed, and had a loss of the target antigen? What you can do, you can switch the bispecific. Now this patient who actually had a very nice response took teclistamab, or AMG 420 here, and then relapsed, and then we put the patient on the other bispecific, talquetamab, and again the patient responded and had another more than 15 months response with the bispecific. So you can sequence bispecific antibodies. So in conclusion, we have 14 new drugs now and novel strategies for patients with multiple myeloma. I think we have dramatically improved the outcome. The question is, how many of these patients are actually cured? My personal opinion is that we are now already curing patients with multiple myeloma, and I have patients that are now 20 or 25 years out of treatment and still in complete remission. So for me, these are patients with their multiple myeloma that are cured. And I think we're increasingly seeing these cured patients with myeloma now. But we also have to consider that there are patients that we do not cure, where we have still the issue that the disease is coming back after 2 years, and these are high-risk patients especially. And what we also know is that T-cell therapies, bispecifics and CAR T-cells are very, very effective. CAR T-cell therapy has the advantage that it's only a one-time treatment, whereas with a bispecific we have to continuously give the drug. And the advantage of the bispecific, of course, is that they are off the shelf. They can be given straight away, whereas CAR T-cells first have to be produced and then reinfused in an inpatient setting. But bispecific antibodies can also be given, as this showed you in this 88-year-old patient, to elderly patients without problems. Considering the infectious complication, we have to give immunoglobulins, we have to screen the patients, and probably we have to extend the treatment-free interval. Yeah, and I think what's very important is that these T-cell engaging therapies, CAR T-cells and bispecific antibodies, are now moving to earlier lines of therapy. And for me, a very important point, if a patient is considered to be a candidate for CAR T-cell therapy, he should not receive bispecific antibodies before. And in the future, we will see the T-cell therapies moving to earlier lines of therapy. We now have trials, I think, here in Norway, you also do the CARTITUDE-6, whereas autologous stem cell transplantation, high-dose chemotherapy is challenged with CAR T-cells. We have studies in which bispecific antibodies are already included in first-line therapy, and also non-transplant eligible patients are receiving bispecific antibodies or CAR T-cells as frontline therapy. I want to thank a lot of colleagues we have been collaborating with, and I would like to thank you all for your kind attention, and more than happy to answer or try to answer your questions. Thanks so much.
Ja, her var det mye informasjon. Og som dere ser, så er det også en rivende utvikling når det gjelder behandling innenfor myelomatoseområdet. Og det er jo det som er spennende å møte de som da driver helt i fremkant på dette. Og da vil jeg gjerne ha spørsmål, kommentarer. Som sagt, dere kan godt gi det på norsk, Nita vil oversette, eller om dere vil gjøre det på engelsk, det er fritt fram. So I'm just thanking you very much and asking for questions. Ja, bak det du skal få mikrofon.
Unnskyld. Det veldig vanlig å få CAR-T-behandling i Tyskland? Og hvor mange får CAR-T-behandling i Norge? Det kan jo virke som at det noe vi kunne tenkt oss alle sammen.
So we now have 45 slots per month in Germany. That means, so it's 540 patients per year receiving cell-to-cell and about 60 receiving Abecma. So about 600 patients per year are treated with CAR T-cell therapy in Germany. And in Norway?
So in Norway, for myeloma, we only have CAR T available in clinical studies, but it's up for discussion in the Beslutningsforum who decides what we can use. But it is approved for a couple lymphoma indications. Så CAR-T i Norge bare tilgjengelig i kliniske studier, men vi har krysset fingrene for Beslutningsforum, som har det på tapetet for tiden. Og CAR-T har blitt godkjent for 2 typer lymfom. Så vi har håp om at det også skal komme for myelomatose innen overskuelig fremtid.
So in Würzburg we do about 100 CAR T-cell therapies per year. And mainly for myeloma, probably 70, 75 myeloma and 25 for lymphoma and ALL.
Så
How much is the price for one treatment in Germany? You see, in Norway, we are quite poor. We don't have the money for treating people at this size of money. So is it cheaper in Germany? Can I go to Germany to get this treatment? Or is it, how is it?
Yeah, so the price is actually going down because obviously Germany is one of the more richer countries in Europe, not as rich as Norway, of course. but because of the number of CAR T cells is increasing all the time, our insurance company said this price is too high, you have to reduce it. So it was in the beginning, it was 450,000 euro, now it's 250,000 euro, and it's probably even going further down. The price is mainly the product. The treatment itself is rather cheap. It's about between 10,000 euro for the treatment with CAR T cells, with all the drugs that are used. But the price is mainly the product which is produced by American companies. And the price in the US is much higher than in Europe.
Var det greit hva pristilbudet var i Tyskland? Mellom 2,5 og 3 millioner. Vi har et av våre medlemmer her som har gjort en CAR-T, eller fått CAR-T-behandling i Tyskland. Vil du vise det fram, Gunnhild? Du har gjort det så masse i media at det tillot å gjøre det nå med en gang. She has been treated in Leipzig.
Jeg var i Tyskland i Leipzig for litt over et år siden og fikk, eller kjøpte CAR-T-behandling. Det har gått veldig fint. Jeg fikk veldig få bivirkninger, og alle prøver og sånn nå fine, og jeg har ikke gått på behandling i Norge siden jeg var i Tyskland. Og før jeg dro så var jeg en gang i uka på Ahus og fikk daratumumab og Velcade. Men det har jeg ikke gjort etterpå. Jeg betalte 5,5 million.
Og nå skal du sykle til Paris?
Det litt pris. Det ikke alltid prisene helt sammenlignbare, men det klart dette en ting som må komme. Og vi har jo vært på, vi har vært med i metodevurderingen med det tidligere legemiddelverket, og vi har hatt ganske heftige diskusjoner med ledelsen i Beslutningsforum, og fortsette med det, hvor vi egentlig føler at det er en vilje, det er en bevegelse i retning av vilje til å få dette innført i Norge. Jeg lover ingenting, men i hvert fall så er dette et høyt prioritert område for oss som organisasjon, at vi får CAR-T tilgjengelig for myelomatose, og også for andre blodkrefttyper. Sorry, I'm just telling that we are engaged in the debate of having this approved in Norway and like to have it very soon, and we are discussing that.
I think one of the strategies to really get the price down is that if we make the products as academic institution, that we're not depending on these big American companies that are putting the price so extremely high up and producing them in our institutions. And I think several institutions are moving this way to really reduce the price and also to be more flexible in generating these CAR T cells, because we obviously are completely depending on the pipeline that they have in the US. So we have to send the cells to the US. They are genetically modified. They're coming back. And I guess that also because the price is higher in the US, there is a preference to serve, first of all, the American patients and not the European patients.
Are you foreseeing that we can do this process in Germany soon?
I
think you have some laboratories.
We are already producing our own CAR T cells, not against BCMA, but against SLAMF7 and ROR2. We're testing them in clinical trials at the moment. Yeah.
That's great.
Yeah.
I think we need more of laboratories in Europe that can do it. I know they work on that I think in Switzerland and Belgium or Netherlands.
Yeah. In the Netherlands. Yeah.
Netherlands, ja. Så dette er helt i forkant på behandling av myelomatose, hvor det er det området hvor det er kommet flest nye medisintyper de 10 siste årene. Så kommer det også nye behandlinger. Kommentarer, spørsmål, det er stille. Skal vi just say thank you to Dr. Einsele for taking time, for sharing with us really the good news about the future. 600 patients in Europe, 100 at your clinic a year. It's amazing, and it's very good news. Hope we are there very soon in Norway as well. So thank you for giving us inspiration for the work. Thank you for sharing with Norwegian medical staff and with all the patients who need to know there is good science for the future. Thank you very much.